Okay, so my name is David, and I'm from Hadassah Medical Center from this division for movement disorder. Sorry, for movement disorder. Just to say that we are four physicians in movement disorder. So the founder is Avinoam Reches, who is still seeing patients, but is partially retired at least. And then there is Dr. Edward Denitsky, Dr. Munira Busnena, that started 2 years ago already, and myself. David Arkadir. So we are four people, and that's to say that we, although we are not, always Dvorah claiming we are not defined as a section. So we have neurosurgery, which is also Parkinson related. We have a gastroenterologist who is helping us. We have psychiatrists and psychologists. Although we are not sitting in the same office, we are all quite tightly linked. And now when there is a Tקוה for Parkinson in Jerusalem, so now I truly believe that people in Jerusalem don't miss nothing that exists elsewhere they cannot get here. I truly believe this, but although we are doing less publicity. Okay, so I'm open for questions. So. Yeah, so the division for movement disorder both doing diagnosis and treatment. So all the four of us. So treatment for Parkinson disease.
Why, if you're running a gait disorder clinic, the emphasis in Parkinson is on walking, or the ability to walk, even though it's basically a neurological problem? That's the doctor next week.
Yeah, no. So this is, yeah. So so our okay. Next week you'll have but I will still next week you'll have a lecture with
Professor Jeff Osgood.
Yeah, with Jeff from Ichilov. He's a researcher. He's not a physician. Researching gait. We are taking care of gait as part of Parkinson and other movement disorder in the clinic. Yeah, but we are not doing currently research on gait. So the research aspect probably will be to next week.
Do you take a holistic approach to the Parkinson's, rather just the neurological, or you?
Yeah, so we tried to take, the question was, do we take holistic approach to Parkinson rather than just to look specific at the, so first let me maybe give a, introduction. So as you know, with the time, medical knowledge becomes so rich you cannot know everything, okay? And in some aspects it's good because there is more knowledge. On the other hand, it's sometimes very bad for patients. I know a patient that has 4 eye physicians, one for the retina, one for the iris, one for the lens, and so yeah, it's a disaster to go to 4 different type of eye physician. So at least me, and I can say it about other physicians as well. So we try to be holistic. We try to take care of the depression, of if it exists, of the constipation if it exists. We try to refer people for social help if needed. We try to take care of urinary problem if needed. But we can't do it up to a point. I'll give you an example. If I will have an impression that the patient has Parkinson's disease, so I will not refer you to a psychiatrist usually. I will start, if needed, the medication. and if he's not reporting a benefit, maybe I will switch the medication. But if I need already a third medication, so then I need help from my colleagues, because then this is already their expert. And on the same in, well, let's speak about urology. So many people with Parkinson, many patients have urinary problems. So I usually try to help and to recommend medication for the urine. So if for a female it's easier to recommend a medication because there are no prostate issue for women, but for a man I can offer a urologist which medication to start, but I would like him to see a urologist before starting the medication, because maybe if he has an enlargement of the prostate, so the medication will cause him, instead of reduce urination, will cause him a blockage. So, you know, we can try to be holistic, but we need, in many cases, to get help from our colleagues in other professions. So the answer is in between. We try to be as holistic as we can. I have the habit not to refer a patient to other neurologists with experts. So if my specialty is Parkinson, but if someone have also a neuropathy or some other issues, so I'm taking care of it. I don't think it's logical to see two neurologists. So up to a point I try to be holistic.
Does Parkinson's always mean involuntary movement? Can you have Parkinson's without the movement?
Yeah, so the question was, does Parkinson always involve involuntary movement? So, okay, so not necessarily. So Parkinson always have to involve slowness of movement. Okay, when you say Parkinson, you say that you must find slowness of movement. Some people don't have slowness of movement, but then they don't have, I cannot say that their Parkinson is in a very high probability, okay? Some people just have tremor. I cannot find slowness of movement, and then I can tell patient, look, the tremor look like Parkinsonian tremor, but there are no other things, so let's continue following you, okay? I'm always telling the truth. If I think it's a possibility, I try to do it gently, but I will say it's a possibility, but I will also say that I cannot say it in a very high degree of certainty that is required. So we know that to say it in a very high degree of certainty, you need to show slowness of movement, okay? Regarding involuntary movement, so there are two types of involuntary movement. There is one which is actually the tremor, okay? And this is not necessarily has to be necessarily have to exist. So in about 20% of people with Parkinson, there is no tremor. Okay, just the Parkinson, just the slowness of movement and rigidity. In about 20%. I think there is also a large fraction of patients, let's say another 30%, but this is a bit of a guess, that they don't report tremor, but when you look at them, you can see a bit of tremor. But so tremor is not the dominant feature, is not a required feature. So this is regarding the tremor. Regarding the dyskinesia. So dyskinesia, I would like to say a few things about dyskinesia. So for those who don't know, until levodopa was invented, and levodopa was found 52 years ago, and actually last week the guy that found levodopa just died. He was 90 something. He was the one that was the first one to show that levodopa is helpful in Parkinson's disease. If Tvo will invite me in September, so maybe we can have a lecture about the history of levodopa. So So dyskinesia are always because of the medication. Okay, before there was no medication, people just experience off state. Okay, which, as you know, is very not comfortable, is very uncomfortable, but there was no dyskinesia. With the invention of levodopa and other medication, so dyskinesia appeared. So dyskinesia is in the involuntary movement. You know it from, I assume, some of your friends, or from yourself, and if you don't know how it looks, you can look at YouTube and look at the movies of Michael Jackson. Michael J. Fox. Sorry.
Michael J. Fox.
J. Fox.
Also
Yeah.
He's going to be our next
Yeah,
speaker.
Jackson is.
He's going to be our next speaker, Dr.
We're
Yeah.
gonna fill the place.
Okay, so first I would like to say about dyskinesia. I always say that if dyskinesia are mild, the dyskinesia are not the enemy. I sometimes like to see mild dyskinesia, a bit of hand movement, because if they are mild, it just say that the medication got to the brain and the receptors are active. And this is actually a good sign, it's not a bad sign. Okay? So this is regarding dyskinesia. At some point it can interfere with daily life, and then already we have to take care of them. Most patients, as some of you know, prefer to be a bit dyskinetic than to be on the off side. And next year there is a conference in Kyoto we publish it.
Yeah, we're going to talk about that.
Yeah, and this is a nice conference. It's in Japan. It's a conference that happens once in 3 years. It's a meeting of physician, researcher, and patient.
And there will be special room with kosher food, and for people who keep kosher, we're arranging.
Yeah, so it's highly recommended. It's a nice city and a nice trip. And if you come to the conference, you'll see that all the patients are dyskinetic, because they prefer to take high dose and to have dyskinesia, because they make them feel more comfortable in a sense. Okay?
They don't take medication and they have the dyskinesia.
No, when they don't take the medication, they have off, they have more tremor and slowness. When they take too much medication, they have the movement. Now, who will get dyskinesia? No, not everybody will get dyskinesia. So if your Parkinson started when you're about 40 years, you're young, so your chances of getting dyskinesia after a few years of treatment is high. But if you got Parkinson when you're older, so your chances at some point you will have the dyskinesia is low. Okay? But I always tell patients, dyskinesia is not the enemy as long as it is mild. If it's severe dyskinesia, so then we have to think what to do, and then we'll go to one of the advanced therapy. We will offer the ones of the advanced therapy, and there are today solutions for dyskinesias. Okay? So dyskinesia is the second involuntary movement you might imply. So it's also not necessarily has to occur. It occurs just in a percentage of patients. So neither the tremor nor the dyskinesia are obligatory. So many patients with Parkinson just have slowness of movement and no involuntary movement. So it was a long answer, but I hope I answered.
What do you mean by advanced treatment?
Yeah, so you know, yeah, the question is what is advanced treatment? Okay. So under the title, so you know, in Parkinson there are few periods. There is the period which actually people are diagnosed and you don't need any symptomatic therapy. Some people, you know, they come to a neurologist just because they have a bit of tremor. It doesn't mean they necessarily need treatment. When a patient asks for a treatment, there is what we call a honeymoon period. This is a period where whatever treatment you will take, unless you will have side effects, you will overall will have a good benefit. And you know, if you once in a while forget to take a pill, also sometimes you don't even feel it. Sometimes you don't take a pill for a week and he's still doing quite good. The honeymoon is changing, I think, like honeymoon in real life, you know. So, some people will have a very short honeymoon, and some people will have honeymoon that lasts for years, many years. Okay? So, but you know, so I'll speak generally.
How much? 5?
No, it can last many years. You know.
More than 5?
Ours was 10.
Yeah, if you are younger, so it usually lasts shorter because the dyskinesia appears faster. But it's, you know, Parkinson, if you ask me about years, I can speak only about statistics, but it's such a variety of variable disease, so you know, you can ask for the mean, for the average, but I don't think you'll...
What's the average?
Of the honeymoon? Roughly, I would say about 5 years.
5?
Yeah, but you know, the average is such extreme to this side and to other side. So for some people, it will be 20 years. Or 50. Okay, and then what happened is that the time of each dose of levodopa is shortening. So you need to take more dosing, and this is, we call it early wearing off. And then after a while, there are also dyskinesia. So you take, in a short interval, you take the medication, there are dyskinesia. So the dyskinesia and the wearing off and few other symptoms, we call it motor fluctuations. Okay? So this is, we said there is time you don't need treatment for some people, there is time with a honeymoon, which lasts differently for different people, and then there is a time of a period of motor fluctuations. Motor fluctuation can sometimes be dealt simply. So sometimes, let's say if someone needs a medication every 3 or 4 years, so he has early wearing off, okay? It's a motor fluctuation. But there is a simple solution, just to take the medication more often. So it doesn't need advanced therapy, okay? So many people don't reach to the point they need advanced therapy. But if the patient has a lot of dyskinesia and wearing off in between, and in between you have bad hours, and you have to always calculate when he's eating the proteins and when this medication will work or not, and if you can be able to go to the theater, this is exactly the time when the medication won't work. So then we have advanced solution, a good solution, but they're a bit more invasive. And once invasive, I would say they're a bit more requiring efforts. So this is a background for the advanced solution. Now I will go one by one to the advanced solution, which again might be not relevant to the majority of patients. Okay, it's important to understand. The easiest way before going to any advanced solution is just to increase the dose and take a bit more doses. Okay? So many people won't need in their lifetime an advanced solution. So what are the advanced solutions? And before maybe speaking about the advanced solution, I would just say that which one is better than the other is a matter of still debate. Okay? So you'll find different physicians think differently. So I'll tell the general lines and not we'll go to a specific which treatment is good to which patient. So there is one solution. Okay, I will speak first about it because it's the one that I have most experience with in Hadassah. So this is the DBS, the deep brain stimulation. It's electrode that you put in the brain, and instead of, if at some point the fluctuation of the day are like this, so people need more and more doses and they have dyskinesia, so it's flattening the fluctuation. There are still fluctuations, but much more flattened. So DBAs are electrodes, and we have in Hadassah, we are a quite big center. 80% of the DBS in Israel was performed in Hadassah, and we have Tzvi Israel, which you should invite for a lecture once. He'll be happy to lecture, and I think he's a world first-class surgeon. And so DBS, who should get DBS? So, first people with motor fluctuation, And second, people who don't have cognitive issue, don't have memory issue. And we try not to take people about the age of 70-something, okay? Because we have other good solutions, not because we exclude them. We have also patients who are 80 who did DBS, but we are more cautious. So DBS is one solution. If you don't have a major cognitive issue, if they have a mild cognitive issue, it's okay. This is one thing. Second thing.
Why do they not do it for people with cognitive issues?
Sorry?
Why is it not given to people with cognitive issues if it's basically
Yeah, we know that if you're going into the operation with cognitive issue, you have higher chance to go out of the operation with worse cognitive abilities. And, if it's a bit, it's not an issue. But if it's a major, major thing.
Could it cause cognitive issues?
So there is a debate if they cause cognitive issue. But I think we know today that if you're passing through a certain path, so there is higher chance that it will cause. If you go through a certain area of the brain, you can go from different directions. And I think mostly, if you have cognitive issues and you already sound once in a while confused, and once in a while you already, you need all your brain cells to work with a full engine in order to be. So every big operation is an issue. It's not just because of the specific the DBS. So did I answer your question? Okay, so do we have this?
What are the other risks of this operation?
So the other risks which are quite rare, we haven't seen them. So sometimes first that it won't be in the right place, so you won't have benefit. Okay, this is one thing. I think we are quite good. It rarely happens, but once in a while we find a patient that we said, okay, this should be 1 millimeter to this side, and maybe you will have a better benefit.
Are you in the operating room?
No, I'm not in the operating room. I'm just doing the program. This is one risk. The second risk is the risk of infection. So in about, I think, 1 or 2 or 3%, we have to pull out the electrode and then offer another operation. Not pulling it, in operating room. I'm not pulling it. This is the second. The third is bleeding. We didn't have significant bleeding. So it's a low risk.
Did somebody die?
Not in the operation, no. In Hadassah, no. In the walk, it's quite safe operation. People who are correcting a block of carotid artery, it's much higher. So but it's still an operation. If you have a problem and you're 1 in 1,000, so you don't care that the other 99, yeah. But so if you're doing well with the medication, why to go to operation?
So what is the percentage of success?
It depends what you call success.
It's help.
It's help, it's always help when you choose the right patient and you're in the right place. But the question if it will help in 30% or 90%. So I think the average in Hadassah is it's help to everyone. And the average is, I will say, between 60 and 80% improvement. Some people, there are always some people who will improve close to 100, and some people will have only 50%.
I was told that it's not a final answer. In other words, if you don't, people think that they do this and then they're cured. But if they don't continue to exercise and everything, they need to stay healthy.
Yeah. I always, the DBS.
What was the question?
Yeah, it's not the final answer. DBS, it's not cure the disease. The Parkinson, you still have to fight the Parkinson. It's not instead of exercise. It's not instead of active life. It's not.
I've seen people who've had this and then they just stay home and they don't do anything. And they say, I've had the DBS, I'm cured.
Yeah, no, DBS is not a cure, and I think it's important to understand that cure we don't have yet, and we just have many ways to improve things significantly. But there is no cure for life and for the years that pass generally, we just try to keep it as much as we can and in the best shape we can. And okay, so this is DBS. Any other question about DBS before I move to the other? Okay. So there is DBS. The second is duodopa. So this is also an invasive duodopa. This is also an invasive procedure. You know, most of you take, I assume, carbidopa levodopa, either in Stalivo or Cinemet or Topicar. But the medication, when you have motor fluctuation, the medication works only for a short time. Not in the honeymoon, when there are motor fluctuations. And this is because the levodopa has a very short half-life. And so the solution was to take the same substance, to put it in a gel, and in a pump that can give drop of the gel, and to have a peg. A peg is a small procedure, but still invasive procedure. When in the end of the procedure you have a small tube that is under the clothes, but it's still visible, that is going out of the stomach, and this is where the pump can be connected. So, and then the pump gives the substance continuously, so instead of taking the medication at high level, after 2 hours low level, high level, low level, you just keep it continuously. Okay? So what are the risks here? So duodopa, first, what are the benefits? The substance, you know, people are familiar with the substance, they already tested, they already been on levodopa, carbidopa, so we know how it works. This is one thing. The second thing is that it's not a brain surgery, so the chance for cognitive impairment are very low. So if you have cognitive impairment, maybe this is the solution for you, no DBS. This is the second thing. What are the risks? The risks are, it looks like a minor surgery, but the risk of the surgery are not less than the DBS, maybe more. Okay? So, and the risk include also death, because there might be infection of the belly. It's rare, but it's not so rare. So everybody in a big center saw it. Okay? The cases I saw, always few days of antibiotic in the hospital, sometimes an operation to clean the area, solve the issues. But it has a risk. It's a low risk, but people have to understand that it's not, you know, people saying, I don't want a brain operation because a belly operation sounds much better. So it's actually both have low risk. The DBS probably have low risk. But both have low risk, but existing risk, and this is important to know. So now, you know, I'm not getting even 1 shekel or 1 coffee from a company, so I'm not obligated to everyone. The company tried to push people for advanced therapy in a very early stage. Maybe they will just do it a bit more pills. They don't need surgeries. But people take risk which is small, but they might not need the risk. Okay?
There's something also that goes like similar to an insulin pump. It's a
Yeah. So this is the second solution. Okay? Advanced solution. The third advanced solution is a pump that it's not invasive. It's like an insulin pump. You know, you have to stab yourself with a small needle subcutaneously. And this continuously gives you a substance named apomorphine. Okay? Apomorphine is not dopamine, but it looks like dopamine. Okay? It's acting the same way as dopamine does. It's not related to morphine. Okay? It's called apomorphine, nothing to do with morphine. Okay? Okay. The problem with this substance, it tends to make more, it tends to reduce the blood pressure more than the other options. Okay? And if someone has tendency for hallucination, so the risk with apomorphine is higher than with levodopa. But on the other hand, this is not invasive. You know, you don't like it after 2 days, always you have to give it a bit more chance because it's time to balance people. But after, let's say, 2 or 3 months, you don't like it, you know, no risks.
It's in the sal?
It's in the sal briut, yeah. People tend to use it less because we all have the experience that people don't last on this for years. After a while, they need a better solution, which is DBS or duodopa, but in the sun.
DBS is in the sun?
Yeah, all the things that he said are in the sun. I'll always tell patients that ask me for a better medication, to tell me if there is something I can pay more and get better. I always tell them that they are blessed to live in Israel when all the good things are in the sun, and that even if you are Sheriari, you won't get a better medication. Okay? So if you have $1 billion, you won't get a better medication. Which is maybe sad we don't have a better medication, but it's good that all the good medication are in the sun. Okay, so now, yes?
I just want to say, dyskinesia, I get it like when I'm wearing off the medication. Is that normal?
Yeah, sometimes there is a dyskinesia on the wearing off. It's called DID, dyskinesia, improvement dyskinesia. Yes. So sometimes there are big dyskinesia, sometimes there are DID. But yes. Okay, so now I say, so all those things are in the sun. So now we'll say what is in the future of advanced therapies, which are, I won't speak at this point about research for cure the disease, which are many research for cure the disease. I won't speak about this at this point. I will just say about what is in the sun around the corner, okay? So there is an Israeli company, also from the Hebrew University, that developed levodopa, a pill that might be continuous for 12 hours. Okay, it's called accordion pill. So there is a pill with nanotechnology, so the levodopa is leaving slowly the pill. The pill is sitting inside the stomach for a while, and then it's a good solution. It's still in clinical trials. Okay?
איך זה נקרא עוד פעם?
Accordion pill. It's actually produced in Jerusalem. What?
And that would be like instead of the pumps or the...
Instead of continuous pills. So, the question, I said it looks like a simple idea. The question is if the level in the blood will be big enough, they cannot soak it with more than a certain degree. So this is where things are still in development. So this is one thing. I'll say that just in the state there is a pill named Ritari, which is also, it's not long acting, but it's probably, you should take it only maximum 4 times a day. So it's longer acting than what we have today. It's not given not in Israel, not in Europe, probably because it's a small company. I have few patients that bring it, and they are paid by their American insurance. I would, if you have American insurance, you can try it, but I wouldn't put money on it because it just, in the end, it's just levodopa carbidopa. So I wouldn't pay. What? Ritari.
Famous with the one?
No, Ritari. Sorry, I don't have an R. Rytary. And so in the end, you don't pay too much money to get, instead of 5 doses or 6 doses, 4 doses. It's not worth $1,000 a month unless you have an insurance that will cover it. But they want, it's the same carbidopa levodopa, so no reason to put a lot of money on it. Okay, so this is regarding the accordion pill, and the slow release pill is one solution around the corner. 1 year, 2 years, I don't know what. The second solution is Neuroderm. So Neuroderm is also an Israeli company. In Israel there's a lot of Parkinson research and success that, if you heard recently, was bought by the Japanese, by Mitsubishi. And you remember that I told you there is a pump, there is a needle that can give subcutaneously apomorphine. And this is because because in order to dissolve levodopa, you need a very acid solution. So they have a pattern to make it in a relatively natural solution, but with some kind of salt. So this is in clinical trials, which we are not now involved with. But this is a clinical trial. The levodopa is given continuously, just instead of what we have today, which is a bit more invasive. So this is less invasive because just the needle. Okay. I have other thing in my mind which I.
So קסדה
Yeah.
של זערור
Okay. This is, I think I have a feeling that I forgot something in the research field. If I remember, I'll say it in 2 minutes. Okay, so those are the invasive treatment, the advanced treatment for Parkinson's disease for those who need it. Okay, but this is the spectrum we have today in Israel. Probably there is more research going on in the world. Now, so this is the end of the topic of the advanced therapies. But I was asked about the helmet, maybe a non-invasive surgery for tremor. Probably you heard about it. It's done in Rambam, and probably we think already in this year it will be done in Israel, in Jerusalem. And I promise you that we will have better results. And because the people who's operating, not because of me, I'm not operating. Okay, so just I'll say a few words about this, and then. So the technique is an Israeli company named Insight Tech, okay? And the technique named FUS, F-U-S, Focused Ultrasound. So this is a way to do a small lesion in the brain, like a small stroke, but very, very focused. They do it with focusing ultrasound and just warming a single spot.
invasive or not invasive?
It's non-invasive. You don't have to cut. You have to shave your hair totally.
7 hours.
Not have to cut anything. But in surgery it's not invasive, but in the way you save yourself, the cut in the skin, but it's invasive in the way that if you have bleeding or something, so it's like any operation. Okay? So you save. You don't see a cut, so we call it invasive or not invasive. In a way, it's irreversible. The DBS, you don't like the electrode, the tissue is okay. You just close the electrode. This is you make a small stroke, and that's it. So you have to be very professional. So I'll tell you. So this is a very exciting technology, but I will tell you what are the limitations now. So one limitation, it's irreversible. Because it's irreversible, so until now, people doing it only for one side of the body. Okay, they're afraid to do it for 2 sides, because if you're doing something irreversible and you did a mistake, you prefer it to be only one side of the body. But already in Switzerland, they started to do it 2 sides. After 2,000 or 3,000 patients who had it in the world, so people get more confidence. Okay, this is one thing. The second thing, we have a lot of experience for tremor with this technology. It's reduced tremor, but no other Parkinsonian sign, no slowness, or no rigidity, no gait, because currently it's done mostly for an area of the brain which is involved with the tremor, for the thalamus. Okay? Now there already works that try to do it with Parkinson patients for all the other syndrome. So probably on the next 1, 2, 3 years, it will be already offered to Parkinson for the same spot in the brain that we put the DBS electrode. So I believe that it will be a good solution, but we still have to gain the experience. But I think it will be a good solution within 1 or 2 or 3 years for those patients who are too old or have cognitive issue to have the DBS, which is a long operation, and they will probably be able to go to this operation, which at least is faster and no calibration and so it's a simple procedure. So we think we'll be able to offer, if we now offer DBS for people depends on your cognitive state until the age of 70 something, even 80. So probably this will enable us to do more things to more people. So hopefully, but this is what Hadassah is still wondering whether to buy this expensive technology, but probably it will be offered in Hadassah soon. But currently it's done in Rambam with a lot of experience. Again, if I was a Parkinson patient, they do Parkinson patient for the tremor. I don't think it's a good solution for the tremor. And so I think Parkinson patients should be cautious before going to this procedure at this point of time. And they also have the machine in Tel Shomer who did much less. And in Hadassah we hopefully we'll have it soon. You had a question? Questions? Yes, I'll repeat the question. So there is a gentleman here who is saying that he takes Dopical once in a while in the night, or take Dopical often in the night, and sometimes he wake up and he saw that he didn't take the pill at bedtime during the night, and if he asked if it was better to take it during the night or not. Is it correct? Yeah. So I will give a more, since I don't know you personally, I will give a more general answer. So people, usually the brain needs less dopamine when he's sleeping, okay? So many people, even if they take medication often, they don't need the medication at night, okay? I want to say. Yeah. So many patients don't need medication. It's very important not to wake up a patient to give him the medication. Okay? If someone is sleeping, so let him sleep and don't wake him, because sometimes I see, physician or patient that understand physician that you have to take 6 times a day. So they divide hours for 6 times, and then in the middle of the night they have to wake up the patient twice. That probably also in between is not maybe sleeping well, and wake him to take the medication. No. Okay? So the time of the medication in the night definitely don't have to be accurate. Is there a reason to give the medication at night? So this is already individual decision. So let's say, I'll give you a few scenarios what I'm doing, but different patients need different solutions. Okay, so one of the option is the patient take the medication in the evening, and until the morning is okay, or in the morning maybe it's a bit stiff for half an hour or so. So you don't have to take the medication at night. If you take it instead of 7 o'clock in the evening, at 10 o'clock in the evening, you will be still stiff in the morning, because the half-life is short. No reason to take it very close to sleeping unless you need it. This is one option. The second option is that the patient wake up in the night with shaking or with tremor or with difficulty moving, and he cannot go back to sleep. So yeah, I would say in this case people should take medication, but they have to remember that it's take the medication sometime to walk, for sometime half an hour, for sometime an hour. So if you are wake up for 2 minutes, you feel a bit not comfortable, but you know that in 10 minutes you're going to sleep again, So, if you take now the medication, it maybe will be good for the next time you wake up, but it won't be good for now. Some patients, especially male, not just male, also female, who need to go frequently to the toilet in the night. So, sometimes they say that in the first time they're waking up and going to the toilet, it's 1 o'clock, so they're walking okay, and then it's become difficult as the night advances, because then there are more time from the last time they took their dopey car. So in those cases, I'm telling patients, when you wake up on the first time, you can take a pill, and it will help you maybe on the next time. But if the next time it's after 5 hours, it will probably won't help. But if you know that you wake up every 2 hours, so it will probably be helpful. So you have to give different solutions for different, but never put an alarm or something to wake up and to take your medication. If you're sleeping. If you wake in the middle of the night and you feel you need it, or you think that in the morning after 3 or 4 hours it will be better if you take it, so take it when you wake up in the middle of the night, but don't force yourself to. So it was a partial answer at least.
I have a question. Speaking of sleeping, does Parkinson affect sleeping habits in any way, or does the medication affect sleeping habits?
So the question is, Parkinson affects sleeping habits? So yes, Parkinson affects sleeping habits, and in many people, so the sleep in many cases become more fragmented. So people wake up many times during the night, and for some patients, it's a really a big issue. For some people, the constipation and the sleeping is the bigger issue than the motor issues. So yes, does the medication improve sleep? So usually the medication improves sleep, or at least when you have to check why the patient is not sleeping comfortably. If he's off, he's stiff, if not to move, so the medication probably improve it. But if you feel that he's not off and still his sleep is fragmented, so then a sleeping pill or something else is possible. So then I would still dedicate a few more minutes to, I think last time in Hebrew, but still repeat it in English. Regarding sleep and Parkinson's disease. So people with sleeping problems, so that their sleep is fragmented, they wake up many times, they sleep very short. So first, always you have to ask, are you tired during the day? Because some people sleep 5 hours in the night, and then during the day they're okay. So no reason to make them sleep longer. Okay, the Rambam was sleeping 4 hours a night, and he was Rambam. I have to sleep 9 hours a day, a night. Okay, so always you have to ask if the sleep was enough. And it's not the time; it's just how you are doing during the day. And with the age, we are sleeping less generally. Okay, baby sleeping 20 hours a day. If you're normal 80 years old, I think 5 hours probably is enough. Okay. Okay, this is one issue. The second issue, if you have sleeping problem, is good to do physical activity a few hours before sleep. So not to do it just 20 minutes before you're going to sleep, because then you have adrenaline. But it's good to be tired like 3 or 4 hours before. So actually, Dvora should consider open evening session.
We did, and people didn't want to come, but...
do an evening session for people with sleeping problems. Yeah. So this is the second thing. The third thing is, if you watch TV at night, or you look at the smartphone, so your melatonin is a bit getting crazy, so this is not a good solution. Also, the fourth thing, don't drink coffee or tea with caffeine after, let's say, 4 o'clock or so. Okay? So take your caffeinated beverages earlier. The fifth thing is always good to have a hot shower before, in the late evening. It also makes you more relaxed. Okay? So this is the thing we recommend for people who still don't want pills. Okay? Then sometimes pills are needed. Okay? So there are generally two types of pills which are popular in Israel. There are other pills. There is the benzodiazepine, like bondormine or clonazepam. So they are long-acting. What do I mean by long-acting? They are not induce sleep, so they won't make you fall asleep fast, but they might stretch your sleep because they are more long-acting. Okay, this is one solution. And then there is another solution, is Zolpidem or Ambien or Stilnox, everybody knows it in a different name. So they are short-acting, but they're inducing sleep. So for people who find it very hard to fall asleep, this is a better solution. But once they're falling asleep, they sleep, so this is a good solution. Or people who sometimes I'm giving Zolpidem for people who they going to 10 o'clock to sleep, at 1 o'clock they wake up, cannot go back to sleep. So I tell them don't take it at 10 o'clock, but if you wake up at 1 o'clock, so this is maybe a solution for you to go back to sleep. With all those solutions and maybe some other medication, we still have problems to deal with sleep in many patients, and yeah, it's still one of the things that for many patients we have to find better solution. But yeah, it's very related. And sometimes it's happened many years, it started many years before the Parkinson. Right?
I'm sorry, we're trying to find because we came very late, so I
No,
don't
it's fine.
cover this. What if we find that the zolpidem, the only effect we're finding is it makes my mother sleep? So at night, if she takes a pill and she'll sleep, and then in the morning she's difficult for her, but she'll take a half a pill, and she'll have to go right back to sleep, and we don't really find any other...
Yeah, so the question was about side effect of sleepiness and drowsiness of levodopa. Dopical can happen with cinnamon. So this is a you know, okay, one of the side effects of Dopical, which don't occur, you know, it's majority of patients won't have side effects, that they take the pill and they're immediately sleeping. Okay? So this is a problematic side effect, and in many cases this limits the treatment, and in many cases it's better not to give the, you know, if you give 1 quarter, you don't see the benefit, you just see side effect, so don't give the quarter.
So is
And
there
I
anything
just tell you that probably all the medication have this potential side effect. Majority of patients don't have it, but it's a potential side effect. And probably levodopa has the least chance of having this side effect. So other substances probably will do it more. So one of the solution, you know, sometime when I know that patients need the medication but they fell asleep immediately after, many times it's happening in the morning dose. Okay? So in the morning dose, one of the options is take it, you wake up to the toilet in 3 o'clock, take it at 3 o'clock, and then anyway you're going back to sleep. In the noon, if you anyway plan to sleep, to have a nap, so maybe take it before the nap. Hopefully that the medication, the side effect is not long. And for some people, just take it at night, maybe even a single dose at night, because anyway you are asleep. But you always have to remember, you know, that if it's generally in medicine, if the side effects are more than the benefit, so don't take the medicine. There are things which are less, which make people more awake, but they less have evidence. So, you know, sometimes we give Ritalin. This is the Ritalin. Sometimes we give Ritalin. Ritalin is amphetamine, so it makes people a bit more awake during the day. One option. Sometimes we give antidepressant, which also have side effect to make people a bit more awake. So this is the second option. There are another medication named modafinil. But those options, in many cases, they're not good options. Okay, it's you know. Once I just say that my training was with a physician who is very important in the States. He's a Jewish physician, Dr. Stanley Fung.
Ah, he's great.
What?
He's well known.
Yeah, and he's not just a well-known physician, but he's also a mensch, okay? Really, you know, it's very rare because at some point you get a very big ego and you start to be a nice person. But he's from the height of his Olympus of intellectual, and he's a very mensch. So once I saw a patient which I thought that giving him or her levodopa will not help. But the chance it will help is nothing. So I suggested not to give medication because I thought it won't help. So he's told, you should try. And I asked, why should we try? So he's saying, because I'm not a nihilist. So you always, even if you have a medication that maybe you have a low chance, as long as you don't think you risk the patient, so you try. So those are the options to try. But I'll tell you the truth. The chance it will work is quite low.
What about Requip?
Requip make people much more sleepy. So Requip is much more, if your mother is Requip, so Requip is a much more side effect. Higher side effect. Requip, amantadine, make people much more sleepy. Definitely Requip, which is a clear side effect. And sometimes people, when they sleep in front of me, I just stop the Requip and they're better.
So if she's getting maybe none during the day, is it good to just for the sake of it, give her at night? But she's going to sleep and she'll sleep for 8 or 10 hours? Like,
yeah, I'm not with the mother, so I'm going to give a recommendation. But this is an option if the Dopical is needed, if the physician feels that she must have Dopical. But if the physician feels that Dopical don't have benefit but just side effects, so we like levodopa, but you also can give up levodopa in some cases.
How, is there any way of distinguishing whether insomnia is caused by the Parkinson's rather other than it being caused by many other factors that cause insomnia?
Yes, and the question is whether insomnia or lack of sleep is because of the Parkinson or because of other reasons. So I don't think that the other reason, neurological reason for insomnia are well known. So I think only what you ask the patient, if he's saying I wake up every 1 hour because I need to go to the toilet, or if he say, so this is there is a way to do it, there is more typical pattern for sleeping in Parkinson that you can detect in sleeping lab. The problem with sleeping lab is that, if it put you in some room, so the chance you'll have a good sleep there is anyway quite low, so you have to do it many nights, so they'll find a specific pattern, and in the end the treatment is the same. This is what we have to offer, mostly. Benzodiazepine or still not, there are trazodone, there are other issues that are less prescribed in Israel. So in the end we ask the patient, we treat the pattern of sleep. But I agree that Parkinson is not the only reason for lack of sleep. But in the end, the treatment is the same. So there's a way maybe to be more definitive about the sleep, but it won't change probably the treatment.
איזה השפעות קוגניטיביות יש לפרקינסון?
Yeah, so what are the cognitive issue Parkinson has? So, Parkinson is just not a motor disease. Some people have also cognitive issues. Not everyone. Okay, it's important to understand that not everyone will have cognitive issues. Many people can live with Parkinson for many years without cognitive issue, but it's a risk. Okay.
What kind of?
Yeah. So the cognitive issue, the span of cognitive issue is very wide. So many people, the most common cognitive issue is that people have what we call tip of the tongue phenomena. So they know what they want to say, but it's not there, but after a minute or two it will be there. It generally happens in the population with the age, but it's very classic in Parkinson's disease. It's called tip of the tongue phenomena. And the second thing is that
Could you say that slowly, the name?
tip of the tongue, קצה הלשון.
And is that kashur to the dopamine? Like, for example, when I get off, I find I have more.
Yeah, it sometimes may be related to the on and off. but sometimes less clearly. You know, people in awe, sometimes they are thinking slower. Okay, it's called bradiphrenia. Like it's bradykinesia, there is bradiphrenia. But sometimes, like you said, people that take the medication think more slowly and after the medication. So this is very individualized. Probably there is a best dose of levodopa that's below it, and above it you think slower. Okay, so the most common thing is what we call tip of the tongue phenomena, and word finding difficulties or name finding difficulties. So this is very common, that, you know, I saw you, what's your name, after 2 minutes. Okay, so those two elements are not necessarily predictor that something bad will happen in the future, okay? This is important. Okay?
But you don't have to have Parkinson's for that.
Yeah, but it's more common in Parkinson's. You know, sometimes they speak and they stuck so many times because they were difficulty, but it doesn't say that it will progress improvements. Okay, this is one issue. The other very common is problem with attention. Sometimes people say I don't have short-term memory. It's not a short-term memory usually, it's an attention. So let me explain what it is. Attention is my ability to do things simultaneously. And no, it's not. No. Attention is the ability to concentrate, but also no. Don't. Okay. Attention is the ability. Okay. I try to connect it to two different things, which are similar. We'll speak about it. Attention, because it's related. Attention is my ability to focus the line of thought. So this is in Parkinson, they might be very distractible. What is the example? So I'm going to the fridge to take something, I open the fridge, I forgot what I wanted to take. It's not a problem of short-term memory. It's a problem that are very distractible. So if I went to the fridge and suddenly thought about what happened in the news, so until I come to the fridge, my thought is so distractible, I forgot what I can do. This is not a short-term memory, okay? And something very similar to this, because there is a problem with attention, is that it's hard for us to do things simultaneously, like multitasking. I'll give you an example. When I'm going into I'm running to the toilet. I was in the car, I ran into the washroom because I have a biological need, and then I put the key of the car somewhere, and then after a day I will forget where it was. Because if you don't have Parkinson, more chances, you know, it's generally with the age, that your brain registers when you put the key on the same time you ran to the washroom. But if you have Parkinson, it's easier just to think about one thing and then to forget the parallel thing. Okay? Or, also in attention, you know, people, if we will hear the news but will not focus on the news, it will be easier for them to forget the news. But if you will be focused on the news and you tell them this is important, so then they have a good chance to remember the news. Okay? And this is different from Alzheimer. In Alzheimer, people are not registering. Okay? Even if you tell them, you know, remember it very carefully what I'm telling you now, they'll forget. In Parkinson, it's different. Okay? Now, some people have more cognitive issue, and I would like to say a few words about the word dementia. So the word dementia is quite frightening word, okay? And I don't want to say that it's a friendly word, I won't say it, but the definition of dementia is that you have two of a set of problems. So the dementia we know is mostly the Alzheimer's dementia, which people have very impaired short-term memory. Okay? But dementia can not be just short-term memory. You know, people who have significant difficulty of understanding three dimension, okay? They have a big difficulty to draw three-dimensional shape. So this is already 1 point in dementia, it's only 2 points. So this is probably won't affect your life. Probably it might affect your driving or something. but you won't, people won't recognize you have dementia. You won't think about yourself as someone with dementia. But still, if you have this and you have problem with let's say, word difficulty problem, which is severe enough, so you get the title, you might get the title of dementia, although it's not the dementia we are imagining when we think about the word dementia. So this is also happening in some point of, in some of the patients. But it not necessarily have to happen. And when it happens, we have certain solution. We don't have a good solution. And there are evidence that the best way to prevent dementia and cognitive issue is exercise. Yeah, so there are work. So the exercise probably has the memory also.
We do cognitive exercise here too, where you have to move the arms in certain ways that really challenge the brain. One of the
Yeah, but I think also, so cognitive,
no, I
you know,
mean,
the best.
physical exercise
Yeah.
which challenges your cognitive.
Yeah, exactly. So physical activity is a good way to reduce the chances someone will have cognitive issues.
First of all, just a comment. You mentioned at the sleep lab, if you need a test, you're in a strange room. Today, you do it at home.
Yeah, it's true. Yeah, it's true that today there is also sleeping lab at home. You're right. But it's already you saw it's already in Israel? But,
Sure.
Yeah? Which Kupat Cholim?
Okay.
Yeah, okay. It's nice to know. Okay.
Definitely.
Yeah, today they give you a, but it's also not perfect, it's also not sometimes easy to sleep with a device.
Yeah.
I know it from the States, but I wasn't aware that you always learn I learn more from you than.
It's a few years ago.
Okay, it's not in all the Kupat Cholim, but okay, I can check it.
You have to go to Miskatladak and they set you up and you go home in the morning, you take
Okay.
it off you and somebody brings it back.
Okay, so there is a report here that there is also a home sleeping.
Okay, but the question I had was, people that are in the early stages of Parkinson, what do they do to stay that way?
Yeah, people in the early stages of Parkinson, what can they do to stay this way? So I won't speak about clinical trials. There are clinical trials, including at Hadassah, but those are clinical trials. So as you know, until now, all the clinical trials, or I think 99% of the clinical trials, try to stop the disease fails. It doesn't mean that we are becoming more and more sophisticated with the time, so we hope we'll in the end will win. But so I'll speak about things that are already here. So probably the best thing is exercise. Okay? And when I'm saying exercise, I'm always recommending patients both lower body and upper body. Do whatever you like with lower body and upper body. The second thing, probably there is less evidence, but probably it's a good thing to be socialized, to interact with people. It's stimulating the brain. To do, if you like to hear music, if you like to read, do whatever you like, but do. Just don't sit passive in front of the TV. This is one thing. And the second thing is the MAO-B inhibitor, which is both selegiline and rasagiline, as elect. Nothing is better than the other. So there were evidence that they might reduce progression of the disease, okay? But the evidence are still debatable, and the FDA considered those medications. It's saying that it doesn't have enough proof, okay? But there are indications, there are hints, but it's not 100% standard.
What with the side effects?
So the side effects of selegiline and rasagiline are minimal, so this is why we give it to majority of patients, but some patients have side effects, okay?
This selegiline,
Yeah.
they recommend but not to take it at night because they could
Exactly.
create the hallucination.
No hallucination. No, the selegiline, okay. Rasagiline and selegiline, two medications. One is Israeli, was produced by Teva. Now there are many generic versions which are probably as good. The rasagiline, you take it once a day. Okay, 1 milligram once a day, and that's all, not more. The sertraline, we have more years of experience in an older medication. You take it twice a day. And the sertraline makes people not hallucinating, but they don't let them fall asleep because there is amphetamine. You know, both medication can. No, it's the sleeping issue. It's with sertraline, which is the issue. I'll tell you why. Because the thing that can cause hallucination because it increased levodopa, it exists about 10 days after you take the pill. So the difference between the morning and the evening, I don't think it's significant. But you know, we always, different patients have different side effects. But usually you tell it to take it in the morning because there is amphetamine that makes people harder to fall asleep. You know, maybe someone is harder to fall asleep, so you have more chance to have hallucination. Maybe it's somehow related. But this is the main reason. Okay, maybe I'll take one last question. Two last questions.
About the doses, is it a problem if you take from the beginning of the disease high quantity of the dopamine or high quantity of how you call this?
Yeah, so the question
is really the fact that it will on the future and things like that.
Okay, so that's taking the medication, or how does the medication accelerate the disease?
Yeah.
Okay, so in the 80s they thought that yes. In the 90s they thought that maybe actually it's protecting from acceleration. Now we say that probably it's not neither, not accelerating. We will have probably a better solution, better knowledge by the end of the year, because there is a study from the Netherlands which was conducted in a good way. But I'll tell you what I'm saying, always to the patient. You know, first, like any medication, higher dose, probably more side effect. Not necessarily long lasting, you can reduce the dose. Always take the minimal dose you feel comfortable with. This is important. And comfortable with is not to feel like you're 16 years old and you can do perfectly, like you feel 90% of what you think is comfortable. So always, this is generally I think in medicine, always take the minimal dose you feel comfortable with. And if you know the medication, you have a bit of tremor, but you don't not interfere with your daily life, so don't take the medication maybe. Okay, so maybe you don't need. But not because it's accelerating the disease, just because probably, you know, higher dose is more side effect, potential side effect.
לפני חודשיים התחיל בארץ מחקר ראשון שבוחן במיוחד באנשים עם מוטציה ב-GBA.
Yes,
אולי זה יוצא אותם מחלה.
Yeah, so today, you know, there are different studies in Israel that are from American companies, and a few studies will start in the very near future that are trying to check strategies to stop the disease. Okay. I'll just name the studies, but to just say that those are studies, they are clinical studies. People always have to, you know, different studies, different physicians are believing in different studies, okay? The studies are based on certain theory, and as you know in Parkinson, we don't know everything, so we cannot build the theory yet and find a solution. And different physicians tend to agree with different theories. So just tell the studies we're now running, but the decision whether to participate in one of the studies of you and consulting your physician who know you. So there is, in Hadassah, there will be a study with mannitol. I won't speak about it now.
Mannitol?
Mannitol. In the center of Israel and in the north, so in Ichilov, in Tel HaShomer, in Beilinson, and not sure that it's in Beilinson, but in Haifa, there are 3 other studies which are targeting, one of the studies, the immunization. It's target alpha-synuclein, getting a shot for antibody against alpha-synuclein. And the second study is, the study you spoke about, is a substrate reduction therapy So it's a study that gives something that's supposed to change the lipid in the brain for those that the lipid might be an issue, which are carrier of a mutation of a GBA. So, all those studies, I won't speak about specific studies, different studies have different protocols, so if you consider one of them, you can check with the relevant center the protocol. All of those, all the studies generally are based on animals, on knowledge from animals. As you probably know, there should be any more sick mice in the world because they found solution for every disease mice have, but not for human. Human are not mice. So all the studies have good logic. All the studies have reasonable safety or good safety, but whatever study people participate in, it's a study to see that it's safe, so it's in a way it's a study. And then which study to join is a house question. So I won't say which studies, different studies have different logic. So it's not, I'm biased, so it's not fair to you. So this is an option for someone with GBA mutation. Okay, so I think
Who gets tested for the mutation?
So, today there is no reason to test for the mutation on the therapeutic point of view.
Maybe for young people?
What?
For young people whose family parents had Parkinson's, and maybe they would want to test if they have the...
Yeah, but then what will you do with the results? But the people we test, so we test either people on a research base. So, if there is a test for GBA PD, also people will be tested for GBA in the center they are taking care. We are also testing for those who are, we think, relevant for certain understanding of the disease, but it's on a research base. And for those who are curious, but then I tell them, if you're just curious, so maybe in 1 year, 2 years, 3 years, the solution will be based on the genetic, and there will be a good reason to test. But at this point, many people will just be more stressed, and then so why to test unless you want to participate in some research, or at least to contribute to research. So this is regarding. Next time that Dvorah will invite me, I will maybe dedicate more time to this.
It's very important.
Yeah. Okay, so thanks a lot, and till tuning in.
Can I just say a few words? I just say a few words about the... Okay, Dr. Aarkadis. Thank you very, very much. We'll be in touch. We're working on all kinds of projects together, so he's a real friend of the Amuta, and God bless him. I mean, really, he's an amazing doctor and an amazing person. A couple of announcements. First of all, there in another less than a year, there is the World Parkinson's Congress in Kyoto. We would like very much that a group of people come from Yerushalayim. There is going to be a kosher food option available for lunch as part of the, anyone who registers can get kosher meals, and there will be a special place where people who eat kosher can eat together. So
what's the date?
It's June 4th through June 7th. Okay, if I'm not mistaken, I have it written upstairs, and the thing I didn't go take it. I'm sorry. It's right. It comes out. It finishes on Friday, and Motzei Shabbos is Shavuos, so it's a little bit of a difficult date for many people, including myself. But it's very, very worthwhile to go to it. There will also be a group of people coming from Lakewood, New Jersey, who will also be eating the kosher with anyone of you who want to join us there. And I assume if anyone comes to our group, you'll all want to eat the kosher food. In addition to that, there will be an option to get boxed breakfasts and boxed lunches. The Congress is unbelievable because you're there with about 5,000 other people, including doctors, researchers, Nobel Prize winners, top doctors in the world, top Askanim in Parkinson's, as well as people like you and me with the disease. And we're all just networking and learning together And it's really an incredible opportunity to gain knowledge and also to get a feel of how important it is to work together to find a cure and to keep ourselves healthy. So that's one thing I will be sending out letters and organizing, and maybe we can all go in a group together. We'll see how we can work this out. We have a long time till then, but they gave me a job from the World Parkinson's Congress to become the official ambassador of Parkinson's in Israel. And I said to my husband, I feel like, have any of you seen The Wizard of Oz? Like, they have, I'm the ambassador. I said, I'm the ambassador of Parkinson's for the World Parkinson's Association. It's a very funny position, but that's what I am. Okay, so that's number one, but I really hope that people will consider going, and I will send out more information. That's number one. Number two, we are very much looking for volunteers to help with a lot of different things here. During the activities, we need healthy people who do not have Parkinson's to be with us, to box with the men, to box with the women, to stand by people who need help with their balance, and work with them one-on-one under the direction of our instructors. It's a real opportunity to do chesed and be part of the community, so anybody who's interested in that, please let me know. We also desperately need drivers. There are a lot of people who want to come to our program and cannot come because the taxis are too expensive. One of the things we're going to also make an option is people who have cars and are coming on their own, that they leave the car, let's say, 2 bus stops away, and we will have somebody drive and pick them up from the bus stop and bring them here and let them off, because parking here in the morning is horrendous. So this is one of the things we're working on, thinking about what we need: volunteer drivers. We also need, okay, this is the big one, we also need funds. Money is, I will just tell you right now that when we have 14 people in a group, which I think is a little bit too large, it almost covers the costs of our